Let's now look at the medial aspect of a hemisphere where we illustrate the basic neural components that make up the limbic system. As we said, this consists of a series of cortical and subcortical structures that are equally represented on both right and left sides. First off, note that the largest and most dominant structures in the limbic system are the hippocampus and the amygdala. The hippocampus forms a major piece of the medial aspect of each temporal lobe, and situated just in front of it, underneath the uncus, is the amygdala. The hippocampus is our memory consolidation center. The amygdala is our emotional response center, situated in close proximity to allow us to attach an emotional content to a memory. Now, beginning with the hippocampus, there has long been a hypothetical two-way circuit that links other limbic, subcortical, and cortical structures together in forming what's known as the Papez circuit. So arbitrarily, this begins and ends wherever we please, but we generally start the Papez circuit with the memory consolidation center, which is the hippocampus. Note that the major fiber bundle that projects out of the hippocampus, although it's probably a two-way street, is known as the fornix. The fornix is an arch-shaped fiber bundle that arches out of the hippocampal formation in the temporal lobe, loops over top of the entire diencephalon, particularly the thalamus, and ends by synapsing mainly in a mammillary body on a corresponding side, making the mammillary body a major player in some aspect of memory consolidation because of its link to the hippocampus. Then, the mammillary bodies send a fiber bundle that projects out to a limbic nucleus of the thalamus, that's known as the anterior nucleus, and the limbic nucleus of the thalamus projects to a major location of limbic system cortex in the cingulate gyrus. The cingulate gyrus has elements that span both the frontal and the parietal lobe, and as you can see in the diagram, the cingulate gyrus is situated directly above the corpus callosum. Then finally, there's a fiber bundle that links the cingulate gyrus back down to the cortical areas adjacent to the hippocampus. Now, one of the degenerative neurological diseases that preferentially begins and affects limbic system structures, particularly the hippocampus, is Alzheimer's disease. Alzheimer's disease results in a progressive degeneration of cortical association areas, but commonly begins with bilateral degeneration of hippocampal neurons that basically, and these degenerating neurons, as you'll hear in pathology, basically exhibit neurofibrillary tangles and amyloid plaques. Interestingly, a common locus or cause of Alzheimer's is the result of a genetic defect associated with chromosome 21. And this is thought to be why that a Down syndrome patient that basically has trisomy 21 is predisposed at an early age to develop Alzheimer's dementia. Alzheimer's disease basically accounts for more than half of all the cases of cortical dementia, and the incidence tends to increase with age. Typically, the initial presentation of a patient with Alzheimer's dementia is memory impairment, particularly episodic memory or memory for events in time in the immediate past. Later on, the patient will have altered mood, disorientation, and they tend to present more commonly with receptive aphasia because the cortical neurons near Wernicke's area in a corresponding temporal lobe are also affected. Classic cause of Alzheimer's dementia is degeneration of neurons in the hippocampus. And the form of amnesia that develops is known as anterograde amnesia, where the patient cannot form new short-term memories from a recent event. So classically, patients with Alzheimer's dementia present with this anterograde phenomenon where they don't remember where they parked their car that morning, where they put their car keys last night. They have anterograde amnesia for events in time that occurred in the immediate past. So this anterograde amnesia is typically a common feature or sign or symptom that presents early on in Alzheimer's patients that later progress to the disorientation, the mood swings, and the aphasia. Next, important to distinguish the anterograde amnesia, which is characteristic of a patient with Alzheimer's disease, with the form of amnesia that's evident in a patient that is a chronic misuser of alcohol that probably has a related thiamine deficiency. So alcoholics typically go through a two-stage phase that begins with an acute presentation of what is known as Wernicke's encephalopathy. This acute presentation, basically when you've had too much alcohol on a single or a single episode, presents with blurred vision, confusion, and the gait ataxia, because we know that the ocular neurons that are innervating cranial nerves, that are associated with cranial nerves 3 and 6 are affected, the blurred vision, and or patients have gait ataxia because, as we know, the anterior vermis Purkinje cells are particularly sensitive to an acute onset of alcohol abuse. If the alcoholic tends to have a more chronic abuse pattern, they may extend, or the signs and symptoms may extend into Korsakoff psychosis, where as a result of the thiamine deficiency, it turns out for some unknown reason that limbic system structures are preferentially affected. And the ones that are affected are the neurons in the mammillary bodies, in the hypothalamus, and in the dorsal medial nuclei of the thalamus. When this patient progresses from Wernicke's to Korsakoff's, generally speaking, there is neuronal degeneration that cannot be reversed with thiamine injections. And these patients not only present with anterograde amnesia, because the hippocampal neurons tend to be affected, but because of the mammillary and dorsal medial nuclear involvement, this patient also presents with retrograde amnesia, where they can no longer recall long-term stored memories from their distant past. And typical of a patient with retrograde amnesia, these patients tend to confabulate. They make up stories to replace memories that they can no longer retrieve. And then finally, what's going to be different about a patient with Kluver-Bucy syndrome? This might be a patient that suffered a sudden drop in arterial blood pressure where the blood supply, particularly of the middle cerebral artery, is depleted from the anterior portion of each temporal lobe, or it can be caused by a bilateral temporal lobe ablation in a patient that has chronic temporal lobe-based epileptic seizures. Regardless, Kluver-Bucy syndrome is the result of a bilateral lesion of both the amygdala and the hippocampus. Certainly, as we've indicated, any lesion or degenerative pattern that involves the hippocampus is going to result in anterograde amnesia. But in addition, since the amygdala is involved in this Kluver-Bucy patient, the patient will not only have anterograde amnesia, they will become placid to all external and visceral stimuli because the lesion involves the emotional response center. In addition, because of the close ties of the limbic system to visceral function in the hypothalamus, this patient has changes in sexual preference. They may become hypersexual or lose sexual preference. They demonstrate what are known as oral tendencies. They try to put everything in their mouth and to explore it orally rather than try to identify it either just visually or using tactile modalities. And because the temporal lobes are involved, this patient may develop a visual agnosia, which we've discussed earlier. That's a form of psychic blindness in the sense that they develop prosopagnosia. They have an agnosia for familiar faces of family members or friends. And then finally, I like to use this MRI, which is a view of the medial aspect of a corresponding hemisphere in almost a perfect mid-sagittal section. And rather than just identifying the labeled lettered structures, we'll use it in the way the exam might. The exam might describe a patient, for example, at the top of the list with Parinaud syndrome, which we know is the result of a pineal tumor compression of the area around the superior colliculus. Patient with Parinaud syndrome have vertical conjugate gaze dysfunction, they have a suppressed pupillary light reflex, and they have elevated intracranial pressure caused by compression of the cerebral aqueduct and the non-communicating hydrocephalus. So an exam question might describe a patient that has Parinaud syndrome and simply ask which letter corresponds to the location of the tumor, and in this case the answer is M, which is the location of the pineal gland. So next, as we just described it, what might be a letter that indicates a degenerative site in a patient with Korsakoff psychosis? Well, we know that the site of degeneration occurs in the mammillary bodies in the dorsal medial thalamus. So now the answer is indicated by letter L, which is positioned directly over a mammillary body, which, as we said during our hypothalamus review, that the mammillary body is the most grossly visible component of the hypothalamus. Next, question number 3, where might a lesion site be that results in just a contralateral leg weakness? Well, we can't basically identify the corticospinal tract as being an isolated lesion because that would cause a complete contralateral upper and lower limb spastic weakness. So the best answer to this is the lower part of the motor homunculus, which is indicated by the neurons in letter D. That's the medial extent of the precentral gyrus that's serving, obviously, contralateral pelvic musculature as well as contralateral lower limb structures. Next, which letter would indicate a lesion site in a patient with a superior quadrantenopia with macular sparing? Well, certainly we know because of the presence of macular sparing, the lesion has to be in some part of primary visual cortex. Primary visual cortex on the picture is illustrated by letters B and C. So the answer is B because we know that what is synapsing in B are the fibers of Meyer's loop that are representing inferior quadrants of the contralateral retina, but obviously what's being processed by Meyer's loop and the lingual gyrus at letter B is the upper quadrants of visual hemifields. And obviously if the lesion is in the lingual gyrus, the patient will have that visual field deficit that's combined with macular sparing. Next, which letter indicates a lesion that would result in alexia without agraphia? Remember, this is not a patient with Gerstmann syndrome. That's alexia with agraphia. This is a patient that has a splenium of the corpus callosum lesion caused by a left posterior cerebral artery infarct, and now the answer is letter A, which is situated directly over top of the splenium. Next, they can use a picture like this to localize cranial nerve dysfunction. So they describe a patient that has difficulty swallowing and hoarseness. And what they're asking is, really, where does the vagus nerve exit from a various part of the brain? And the answer would be H, because we know that the vagus is a rostral medulla nerve. Difficulty chewing has to involve the trigeminal nerve, and the motor fibers of the trigeminal nerve are exiting from the rostral pons, approximate letter G. And next, where might be a center, a neurologic center indicated by a letter that's sensitive to temperature changes, temperature regulation? And now the answer has to be hypothalamus, which is indicated by the letter I in the lower part of the wall of the third ventricle. Rathke's pouch, remember from developmental embryology, that is a remnant of the anterior pituitary, and certainly the pituitary is situated as encased by the bone of the sella turcica at letter K. And then finally, where might a lesion site be that causes a truncal ataxia? We know that that is unique to the posterior part of the cerebellar vermis that's indicated in this MRI by letter J. So again, don't just memorize and learn what various brain parts are, although that is certainly a prerequisite. Know what signs and symptoms might be associated with various lesion sites and be able to identify them, as we've done in this slide, by using various letters on the medial aspect of a corresponding hemisphere.